welcome to this next talk. My name is James. I am going to be speaking to you for the next 25 minutes, and then we'll have a chance afterwards to do a Q&A. I'm probably somewhat of a rare breed at conferences like this. I am a psychiatrist, I'm a consultant, and I'm based in London, where I work in the NHS in an adult ADHD service part-time, and the rest of the time I have a clinic based in Harley Street in London, where I see the full range of mental health difficulties that one encounters in adulthood. But probably about 50 to 60% of the work that I do involves seeing people with either suspected or established adult ADHD. And it's a very exciting area to work in for lots of reasons. And hopefully some of that will emerge during my talk today. Over the last 15 years, I've developed a particular interest in ADHD, and I've got involved in a variety of capacities. I sit on the executive board of an organisation called UKAAN, which is the UK Adult ADHD Network, which is the main professional organisation for adult ADHD in the UK, responsible for doing all sorts of things, but a central focus is training, and I'm the training programme director. So we have a team of some of the leading experts in the field as part of our training team, and we run multiple trainings throughout the year, teaching people how to properly assess and diagnose ADHD and effectively manage it, both looking at medication management, but also a more psychosocial approach. It's been a very exciting 10 to 15 years, because the field, a bit like the field of hypermobility, has had its struggles in terms of being taken seriously. Many people believed that ADHD miraculously disappears at the age of 18, which it clearly doesn't in the majority of people. And so the whole concept of adult ADHD has only been understood properly over this period, and along with it has been a rapid increase in awareness and in parallel to that, education. And it's been fun to be at the forefront of that process. We've seen real change with much more recognition and much less stigma around ADHD. So I can honestly say, though, that not many of my colleagues would really understand what I was doing presenting at a hypermobility conference. But over the last couple of years, I have been speaking to them about this relationship, which I've become fascinated with, and that is between ADHD and EDS, or more broadly, hypermobility spectrum disorder. I think there is an understanding that there's higher rates of mental health problems with hypermobility related issues, but what happened over the earlier part of my career, when I was seeing a lot of people with ADHD, is as part of my routine assessment, I was hearing that quite a disproportionate number of people had hypermobility, and after some reading and learning, I realized that in addition to the joint-related issues, there are a whole range of other problems. So I looked at this more formally and started finding about a third of my patients met the criteria for, at the time, Ehlers-Danlos syndrome. Things changed a little bit in the last few years. A third of my patients with ADHD were meeting the criteria for another disorder, and most of my colleagues don't really recognize an association or connection. And I think it's really important to recognize it, and I'm going to try and explain why. Here's my disclosure slide. I won't read through it, but I've been involved in various projects. I mentioned the training. I have been a co-author of a handbook for ADHD in adults. And as I said, I have a clinic in London. Okay, what are we going to cover? I mean, this is going to be a real sort of whistle-stop tour really through this topic. To try to talk about ADHD in 25 minutes alone but to try to bring in the idea of hypermobility spectrum issues alongside is challenging. So you're going to have to bear with me. I think this talk is being recorded. If you want to come back and have a look in more detail, I am going to move quite rapidly. We're going to talk a bit about ADHD, introduction to ADHD and some of its history, a brief look at what's going on in the brain. We're going to overview what it takes to get a diagnosis of ADHD, not the practicalities necessarily, but the criteria. And a look at the topic of ADHD and comorbidity. Comorbidity is essentially co-occurring disorders. We know that when someone presents with ADHD, in 75% of cases, they're going to be presenting with at least one other mental health condition. What's not really understood as well is what I would refer to as the somatic comorbidity, the comorbidity or co-occurrence with physical health issues. We're going to touch on that and then hone in on EDS specifically. And then I'm going to talk about my own experience of working with this population, this dual diagnosis, as it were, and some of the things I think are really important to mention. Okay, let's kick off. So, first of all, what is ADHD? Well, it's what we term a neurodevelopmental disorder, and that means a disorder of the brain that occurs during development and continues in a trait-like fashion, usually. Now, many people struggle with this concept, but ADHD isn't something that you either have or don't have in a binary way. It's really a cutoff. It's on a spectrum, a bit like blood pressure is on a spectrum. At some point, the blood pressure becomes impairing or problematic or pathological, and it's the same with ADHD. The interesting thing about this disorder is that, you know, we can all connect with being a bit inattentive or a little bit restless or hyperactive, or perhaps being a bit dysregulated in our emotions at times. But the reality is it's the frequency, the intensity, and the degree to which those difficulties cause you problems in life. And ADHD really marks the cutoff point where this particular cluster becomes impairing and therefore pathological. As I mentioned, it was previously thought to be confined to childhood, but we know that's not the case, and I'm going to show you some data briefly there. Broadly speaking, there are 3 symptom clusters, although I would argue there are 4. They are inattention, hyperactivity, and impulsivity. And I would say the 4th is mood related, and included in that would be mood instability or emotional dysregulation. ADHD is all about a problem with the regulatory function of the brain. And that extends to the mood, so emotional dysregulation, and also the impact of ADHD, lifelong ADHD, on one's self-esteem, which is a real problem. We know that ADHD is associated with lots of comorbidity, and we know that there's a really well-established treatment response, and that the medications, particularly we use for ADHD, really work much better than many other psychiatric medications and physical health medications for that matter as well. ADHD is not a new thing, and this slide would suggest that it came about in the last couple of 100 years, but I'm going to just show you an interesting new angle on that. But the first time that the syndrome of ADHD, it wasn't called ADHD, but the syndrome that looks like ADHD was described was by a doctor called Heinrich Hoffmann, who wrote children's books, and we're going to see a couple of extracts from his books. And the first time that it came really into the medical sphere was by George Still, where he, in a lecture to the Royal College of Physicians, referred to it as, well, a similar presentation as what he termed a morbid defect of moral. Other names over the years: minimal brain damage or minimal brain dysfunction, hyperkinetic reaction of childhood, but it was only when in the Diagnostic and Statistical Manual number 3, the term ADD, attention deficit disorder, with or without hyperactivity, and later in 1987 the term ADHD was coined. And you have to be aware that in the UK we refer to ADHD to cover all types of ADHD, The concept of ADD is a more American thing. So when you are talking about ADD, attention deficit disorder without the hyperactivity, you refer to it as ADHD, predominantly inattentive presentation. In 2013, the main classification system we use, DSM, specifically made adaptations to reflect ADHD in adulthood, which was important because we all know it's there, and it is very important to recognize it. Actually, the story probably goes back much, much further. If you look at the writings of Hippocrates, you can extract comments like this, where he described a cohort of patients with quickened responses to sensory experience, but also a less tenaciousness because the soul moves on quickly to the next impression. He referred to this as being as a result of the overbalance of fire over water, which I think makes a lot of sense. And his remedy, interestingly, was barley rather than wheat, perhaps reducing the gluten content slightly, fish rather than meat for omega-3, water drinks, hydration being important, and physical activity. So he actually was spot on with this treatment. So this is a couple of the cartoons by Heinrich Hoffmann. Story of Fidgety Philip describes what he's doing. You can read an extract from the story, but essentially he won't sit still, and he tilts his chair and falls off and pulling everything with him. And then there's a story of Johnny Look in the Air, who represents more of the inattentive type of ADHD, staring in the sky and doesn't see the river that he falls into. So what do we know about the prevalence of ADHD in adults? Well, at first glance, it looks like only a small number of people retain full diagnosis when you go from childhood to the age of 25. But then when you look at it in more detail, 50% of people are continuing to get impairing symptoms, which means about 2/3 of people, children who go through to adulthood will have persistent symptoms. And actually, more recent data suggests this is a gross underestimation. It does depend on the type of ADHD that you look at. The prevalence of ADHD in the population is between about 2.5 and 4.3%. That's in adults. I go more along with the 2.5 mark. And as you go through the lifespan, you will experience many different facets of ADHD, and the impact of it plays out in different ways. And you can see on that slide the various problems that come at various stages. I'm not going to go through that now. And ADHD is referred to as a heterogeneous condition. It can present in many different ways, and here's just a scattering of cases, real cases, just to give you a flavor of the diversity of the presentations and the sorts of people. ADHD is nothing to do with intelligence. People might respond differently to it depending on their intelligence, and often more intelligent people, high functioning ADHD, are really able to capture the different functionality of their brain and use it to their advantage, and really turn it on its head and make it a very powerful strength. Okay. We've had a whole flurry of database studies where countries that capture information on their database systems cross-reference it and make associations. And we can see that the risk of all these problems listed down the side is massively increased in ADHD. Anyone who says that ADHD is just a slightly different personality and there's no big deal is quite wrong. We know that the rate of criminal convictions and offending, other mental health problems, substance misuse massively increase. And we also know the treatment of the ADHD reverses many of these figures. So what's going on in the brain? Again, we're going to just keep this to a bare minimum. We're dealing with some important areas. It's really this interplay between the frontal part of the brain and the subcortical regions, so the limbic system and basal ganglia, and also some impact of the cerebellum. But really, the best way to understand ADHD is that the prefrontal cortex is essentially, to a degree, offline. And the function of that part of the brain is to regulate the whole system. It's like the conductor of the brain. And if you reduce regulation, and in particular inhibition is like the brakes, calming, slowing everything down, you can see how a system quickly becomes dysregulated. Again, brain mechanisms in ADHD, what causes ADHD on a brain level? There's so many different models, but some of them are listed here. Certainly the reward system is very heavily impacted, explaining the association with substance use, and this whole concept of executive function, executive control being weaker, as I mentioned. When you diagnose ADHD, you do it according to criteria, and the criteria that define adult ADHD are listed here. So you've got to have a certain number of symptoms. I'm going to show you the different symptom columns. They have to be present before the age of 12, and they have to be present in multiple settings and cause you problems. Here are the specific list of symptoms. So to diagnose ADHD, one of the things you need to have is to meet the criteria of 5 of the symptoms in either column. The diagnosis can be of ADHD combined type, or predominantly inattentive type, or predominantly hyperactive impulsive, and there's another category for in partial remission. So again, I don't want to labor this. This is something you can look back on if you like, but here are some of the common inattention-related problems. It extends to things like organization and time management and task management, really impacting your ability to function on a day-to-day basis. The distractibility, this mind wandering, is particularly challenging. The ceaseless mental activity of ADHD can really cause major problems, sleep problems, etc. Difficulty shutting down, relaxing, unwinding. And the impulsivity of ADHD, not in everyone, but those who do have the more hyperactive impulsive type, can be highly problematic, lead to all sorts of complications listed there. And we talk about comorbidity, and this is one neat little way to overview it. The comorbidity in ADHD can be sort of broadly split into these areas. There's the comorbidity that's linked with impulsivity, so obesity and substance use and gambling and so on. The comorbidity that's linked with a shared relationship with other neurodevelopmental problems, shared genetics, and then issues related to the mood, which maybe have a genetic basis, but often have the impact of untreated ADHD. It's like a fire in the system, essentially. It's a stress in the system that, you know, is going to bubble out and burst out at some point. Here is some of the data looking at the risks of co-occurring disorders, and what you'll note is a lot of mood disorders and a lot of anxiety disorders and a lot of substance use. And if this is an interesting slide because it compares, this is a group of people with ADHD and those without ADHD, and they had a little monitor in their hand all through the day. Whenever their emotions became dysregulated, they would press the button, and you can see the top half is ADHD. Each long line is an individual patient over a 24-hour period, and you can see there's a lot more dark compared to the control group. Now, it's this issue of somatic comorbidity that acts as the link point with hypermobility. The idea that medical conditions can cluster together with ADHD, but some of them can actually lead to ADHD symptoms. You know, if someone has a problem with their thyroid gland, for example, they might present with what looks like hyperactive ADHD or inattentive ADHD. So it's a complicated picture. Many of the other physical health problems have shared causative risk factors, and it's important that to be aware that ADHD, alongside these other conditions, can sometimes complicate their management. You know, if people are inattentive and not managing their physical health care properly, then they're obviously not going to get optimal treatment. Those are some of the associations in terms of physical disorders. I'm just going to draw your attention to the one at the bottom, which is EDS. And just to be clear, this list was adapted from the American Psychiatric Association DSM manual. It doesn't mention anything in there about EDS. That's one I've added on. It, I think, represents the fact that we're at an early stage of understanding in this relationship. And this slide really talks to that. We know that in EDS or HSD, there are lots of associations with mental health and psychological dysfunction, and some of the issues are listed there. Anxiety is high up on that top of that list, and there's reference to neurodevelopmental issues, but more recently there's been an extension to the reference to attentional difficulties in EDS, specifically looking and mentioning ADHD, and there's an increasing body of evidence that the ADHD prevalence is significantly higher in those with EDS. And the first study I came across, which really shocked me and excited me in order to understand this better, was this 2001 Turkish study where they looked at 54 children with ADHD, they assessed them for joint hypermobility syndrome, and found, similar to my findings in my clinic, that about a third of them met the criteria. There's been further papers, particularly a good one by Jessica Eccles, looking at this relationship between ADHD and hypermobility, and particularly drawing attention to this issue of autonomic dysfunction. Now, I would like to direct you to my previous talk for the Ehlers-Danlos Society last year in Edinburgh, because I go into this link and this connection in a lot of detail, and I don't want to repeat that now. So if you do want to explore that in more detail, please go and have a look. But essentially, dysautonomia is a central issue when it comes to understanding this link between the two conditions. But there are other explanations for it. And you can see a neat diagrammatic representation of the relationship. But I'm going to just hone in there briefly and mention that dysautonomia is often associated with something called orthostatic intolerance. This is basically experiencing symptoms when you stand from sitting due to insufficient blood supply to the brain. The problem is when that happens chronically at a low level, it's all very well when you stand up, feel dizzy and pass out. That's acute orthostatic intolerance. But if you look at that chronically over a long period of time, it's much less clear, much more vague. And the key message here is that the symptoms of orthostatic intolerance, this lack of blood supply, effective blood supply to the brain, are there in red, and they map very closely onto the symptoms of ADHD. So there's significant overlap, you know, if you look at the body's response to orthostatic intolerance, it includes, well, either lying flat or pacing, bouncing, calf pumping, activating the stress response. You know, these are all features that can easily be confused with a clinical picture of ADHD. So finally, to bring things to a close, how do I think about my patients who have both ADHD and hypermobility related issues? Well, here are some of my reflections. Each one could prompt a long discussion, but essentially the key messages for you to take home are that don't miss the diagnosis of ADHD in yourselves, in your family members. It's important that screening of both conditions takes place with each of them. So screening for EDS in ADHD is part of my routine screening process now, and screening for ADHD in EDS. Try to differentiate the symptoms of each condition, but recognize that both conditions impact on the other's group of symptoms. I think recognizing that some of the symptoms of ADHD might be problematic in terms of higher risk of injuries due to the impulsivity and risk-taking behaviors. Recognizing that ADHD, with its executive function difficulties, organization and time management and task management problems, can really impact the ability to optimally manage EDS. You know, you have to turn up to appointments with physiotherapists and doctors. You have to take medication on a regular basis. And if you are struggling in these areas because of your executive dysfunction, it's going to make the whole thing a lot more complicated. And that's certainly what I see in my practice. I think, again, one of the theories around why ADHD is more common in EDS is that the pain of the disorder essentially zaps your energy that would otherwise be used for attention. And I think it's important to make sure that the EDS-related pain is well treated. And then finally, a real focus on orthostatic intolerance. This is an area that you can treat quite effectively in many cases to a large degree with very simple conservative management approaches. Wearing flight socks or compression stockings, you go to Boots and buy, they've got two different types, buy the slightly higher quality ones. They're like long socks essentially, and you normally wear them for flight to avoid deep vein thrombosis. But what they do is they essentially shift the blood up the system and counter the orthostatic intolerance and relieve symptoms in a dramatic way in some cases. Hydration is essential, as you all know, as is salt intake, assuming your blood pressure can tolerate it. Calf pumping whenever you feel dizzy or lightheaded. And in terms of using ADHD medications in this population, people with hypermobility issues, sometimes the side effect of the ADHD treatment you're using, for example, a stimulant like Ritalin, one of its side effects is to push up the blood pressure a little bit. Always seen it as a bad thing, but in this population, it's often a really good thing because blood pressures can be low and worsening that orthostatic intolerance. Just a cautionary note, you will all be aware that there's a heightened sensitivity to medication, and particularly psychotropic or psychiatric medications, exquisite sensitivity sometimes. So start low, go slow is the mantra. And I think it's really important that when you're using ADHD medications that can cause lowering of blood pressure, hypotension, medications like Intuniv, that you watch carefully, because some people with EDS and orthostatic intolerance can really struggle in those areas. That's my inattention. I was going to finish this slide, which says, most of all, celebrate the wonderful, I don't like to say positives, but positive traits associated with this population. Many people are looking, some people are looking at the association with genius, along with some of these hypermobility related issues, something about flexibility, and both ADHD population and the EDS population, if they're able to manage their conditions well and take the strengths that come through it, that can be a really positive thing. So I'm going to leave it there. I think I've run over time slightly. I'm apologizing for that, but as I said, to try to get all of this information into 25 minutes is pretty tough. Anyway, it's been nice talking to you and look forward to your questions.